All right, we're going to do this in a quick fashion because I have about 30 cases. I'm going to show you, in some instances, only in a single image, and in other instances, several images on one slide, and then go through all of the unknown images first, and then go back through them again with the same images and a diagnosis. We'll talk about a few findings later as we go through them with the diagnoses. I haven't figured this one out yet either. I have no idea why this woman's dens is several centimeters long. But I thought I'd learn something myself. I think you've seen this today. I know you've seen this. I guess I'll know if you paid attention. I guess I'd give you a hint here. This patient was had a seizure disorder, but had not been ill, was not febrile. And this patient has von Hippel-Lindau. This ought to look familiar as well. We have fetal diagnosis and postnatal. I showed you a fetus with this diagnosis earlier. This I couldn't resist putting in. I just did this last Friday, this fetal case. This is all the same patient. There's a finding, at least one finding on each image. All right, I think that is the last case. So now the answers. This is an axial CT image with In the left lamina, a very dense lesion surrounded by lucency. What's the answer? I guess this child did not survive the ejection from the automobile, and you can see that the occiput is too far away from the ring of C1. On an axial CT image, you should be able to see both of those findings together, and the atlantoaxial interval is also widened. Retrovertebral soft tissues, or prevertebral soft tissues, retropharyngeal soft tissues are widened as well. And so we have dissociation of the atlantoaxial and atlanto-occipital joints. This child did survive his accident. If you look here, you should be able to count seven vertebral bodies. You have 2, 3, 4, 5, 6 is just this little sliver of tissue. This is 7, plus the back of 6 doesn't really line up with the back of 7, and that's usually pretty bad. The first image we had was this chest radiograph that shows a lot of chest findings here with a hematoma and hemothorax, but also a wide separation between this part of 6 on the left side and this part of 6 on the right side. He had transected his spinal cord at C1-2 as well. Although I don't know why this patient has such a long dens, this is the apophysis between the dens and the body of C2. She also has basilar invagination. The dens is up way too high. It's causing mass effect on the ventral aspect of the medulla and cervical medullary junction. Probably the cause of this little syrinx here in the central part of the cord. This child's spinal cord comes way down here, way too low. It should end normally at 1-2, and it comes way down too low. There's a little dystrophism, a little bit of fat extending into the canal, a little bit of abnormal fat outside of the canal, and nerve roots extending out. So this child has a tethered spinal cord by his lipomeningocele. On T1, this is a very uninteresting mass. Other than the presence of the mass, it doesn't really expand the spinal canal. With gadolinium, it gets more interesting. Here, a magnified image where it gets more interesting, and this ependymoma pushing the spinal cord ventrally. This patient was had plethora of findings. Here we have that beaded appearance of fibromuscular dysplasia in the internal carotid artery, the arterial venous malformation, the abnormal venous and arterial structures with early venous drainage. You got all this arterial stuff and arterial enhancement here in the carotid, and you already see the venous drainage that's abnormal. It's important to know whether the venous drainage is central or peripheral, how large the lesion is, and are there aneurysms or other associated findings with usually aneurysms within the nidus. This patient has a bonus aneurysm at the basilar tip. It's not really a bonus, is it? Okay, we've looked at this vena-galen malformation already. This is just a different view showing the venous signal in the aneurysm and the straight sinus. Colloid cyst is high attenuation on CT, and it is also high signal on a non-infused T1 because of its proteinaceous contents, and calcium, which can make it high attenuation here, can also make it low signal on your T2. I thought this one was kind of cute because you can actually see the left lateral ventricle is normal volume and the right lateral ventricle is enlarged, and of course hydrocephalus is part of the problem leading to the drastic effects of this tumor. Arachi's cleft pouch, part of that big, long Satchmo differential that those of you that are preparing for the board examination are going to rattle off probably even faster than I can. Just a good example, it sort of looks like a pituitary macroadenoma, which is why it fits into that differential so well. Hypothalamic glioma, this is actually coming not from the sella. The sella really is probably normal volume and this big mass sitting above the sella, so this doesn't look so much like a pituitary tumor, although it does look rather like that here. The brain edema here kind of tips you off, and although pituitary macroadenomas can get this large, they generally don't put this much type of edema in the surrounding brain because it takes much longer for them to grow, and they're not growing out of the brain but pushing it up instead. Yet another part of that Satchmo differential, and this abnormal enhancing signal and big mass, again, pushing the brain up. This is meningioma. Aqueductal stenosis, the tectum structure here, the superior colliculus is pushed back, the inferior colliculus sits adjacent to the midbrain in its normal position, and there's a little bit of flow or CSF that fills that space. This is a typical appearance of aqueductal stenosis. If you have marked enlargement of the third ventricle, which thins the corpus callosum that is draped over top, this is part of the occipital horn of one of the lateral ventricles. So marked supratentorial hydrocephalus. This is a glioblastoma multiforme. It's coming across the midline, not too much abnormal signal in the right cerebral hemisphere as yet. This was a ganglioneurocytoma. The hint I gave you was to hopefully make you think that this was not herpes encephalitis. Herpes encephalitis is typical to involve the mesial temporal lobe, and so it's part of this differential, and it's certainly something you should think about. But in an otherwise normal patient, and probably someone that's had a seizure disorder for many years, a low-grade tumor is far and away the leading consideration here. This person has an enhancing nodular mass in the posterior fossa. It's very vascular. You see here on the cerebral angiogram. This is hemangioblastoma. And Dr. Rosenblum showed you a couple nice examples of lymphoma earlier. High attenuation mass on CT presumably because of the densely packed cells, and a very enhancing mass. And again, this can be multifocal, supra and infratentorial. A tectal glioma also causes suprasellar hydrocephalus. The lateral and third ventricles in this patient are quite large. On the axial image, you can tell that this is arising from the tectum. Here, the tectum tissue is just this little bit of the superior colliculus, so we can see normal tectal tissue. And so because of outflow obstruction through the aqueduct, you have hydrocephalus above and a normal volume fourth ventricle. This person has what looks like tumor, very large, high signal region, low signal on T1, looks like lots of edema, but we don't really see an enhancing mass in the center of all of this. You wouldn't expect just from this degree of enhancement that if this were a neoplasm, which really doesn't look like that nice round tumor, if this was neoplasm, you would expect that the the edema would be all the way around it rather than extending outward in this type of fashion. So other considerations, this is tumefactive multiple sclerosis. MR spectroscopy can help you differentiate that occasionally because the NAA peak and choline peaks are going to be more normal, but you still may have a big lipid and lactate peak there. This patient I showed you this image earlier with the bilateral acoustic schwannomas, but you can see all of the multiple meningiomas around this patient. This is a fifth cranial nerve schwannoma. The third cranial nerves, she had a third nerve neuropathy, so there's some involvement that I'm just not showing you here. Also, this large mass in her neck that extends intradurally. This is a patient that has a normally pneumatized sinus on the right, but not such a normal sinus on the left. You can see here the nice definition of the cortex of the inner table of the calvaria. Really, it just disappears. It's totally destroyed on the other side. And intracranial extension of pus in this abscess, multifocal abscess. In this patient with neurosarcoid, there's abnormal enhancement, lots of peel enhancement supratentorially, but really a paucity of enhancement in the folia and the leptomeninges below the tentorium. These two patients do not have a normal corpus callosum. I showed you this image before just to reiterate the parallel configuration of the lateral ventricles, slight dilatation or colpocephaly, the occipital horns and atria, and those Probst bundles that sit along the roof of the lateral ventricles kind of show you this kind of longhorn or steer horn kind of a configuration of the lateral ventricles, which you're kind of sort of wondering if that's sort of developing here, but you don't have that normal connection, that corpus callosal fibrous tract communicating between the lateral between the cerebral hemispheres here. And so you have this large space that's abnormal. In this child with holoprosencephaly, there's not normal cleavage of the cerebral hemispheres. Pathologically, although this looks like frontal lobes and everything else is absent, really what's absent here is the frontal lobes. Histologically, this tissue looks more like parietal and occipital lobes. My case from last Friday with brain extending through the cleft in the occipital and parietal lobes. There's brain tissue extending backwards, here extending through, similar to what this child would have looked like, except this is a much larger encephalocele. And this patient with tram tract type calcifications, very dense on the brain windows, in a patient with Sturge-Weber. Adrenal leukodystrophy is a dysmyelination disorder, and you can see that abnormal signal beginning posteriorly. It marches forward. Usually, the leading tract of that will enhance. And so, even though you see lots of signal abnormality back here, that tissue doesn't really enhance, but it's this leading margin that enhances. This young lady has a fracture of her nasal bone, the lateral wall of her orbit, and the floor of her orbit. Here again, the lateral wall. She has a fracture of lamina papricia. You know this is an acute fracture because there's blood or fluid within those ethmoid sinuses. The ones on the other side are perfectly fine, as is the sphenoid. And she also fractured the superior orbital rim in this orbital blowout fracture. Important points to keep in mind is where is that medial rectus muscle? If the medial rectus muscle still lies within the orbit, or there's a nice fat plane, that's wonderful. The other thing with the orbital floor fracture is to look for the inferior rectus muscle. Entrapment is a clinical finding. The clinician has to take their fingers and try and move that eyeball around. And while we get a lot of requisitions that ask us to rule out entrapment, that's really a clinical finding. We can tell them what's herniated through a fracture, if anything. This child has this thin rim of high attenuation epidural hemorrhage, which sees slightly less well on this later image after it's been drained, and has a fracture of the temporal bone. A partially calcified, partially necrotic mass with a thin rim of edema on CT. All these findings are confirmed on the pre-contrast T2 image, and the necrosis and marked enhancement of this mass with a little bit of midline shift. This thing has been here for a long time to be able to grow this large, and must have been there for a long time to only have that little bit of edema. One would think we would notice, that the patient would notice things weren't quite right well before something got this large. This heterogeneous signal mass in the medulla with some very low signal areas indicating that there's probably been prior hemorrhage here, a little bit of enhancement as well. Hemosiderin makes that low signal, and this is a cavernoma. And this patient with abnormal high signal in the mesial temporal lobes, which may enhance slightly, but really not very significantly. It's a bilateral process, much less likely to be tumor in this patient with limbic encephalitis. Thank you.
We're going to talk about extrathyroidal spaces of the neck. Usually neck imaging is divided into the suprahyoidal region and the infrahyoidal region, which is anatomically appropriate, but practically makes no sense whatsoever. I'm going to give more time to the thyroid gland because there are a lot of critical clinical and radiological factors associated with it, and we've got to be aware of them. Now, all of this is in your syllabus, so you don't really need to write anything. We're going to talk about modalities of imaging, the spaces in the neck and non-nodal mass lesions. Going to devote some time to neck lymph nodes, but we're going to talk about this more in detail when we talk about PET imaging later on in the week. A little bit about the brachial plexus and briefly touching upon the role of MR angiography, more on angiography using MR and intravenous contrast during the neuroanatomic sections. So what are the ways in which we can look at the neck? Sectional neck imaging, non-FDG isotope studies, and of course the big one is FDG PET imaging. And PET has revolutionized the way in which we look at neck, for neck lymph node pathology as well as head and neck cancers. So very, very important to know about PET within the neck itself. In sectional imaging, we use CT and MR. These are the mainstays of neck imaging. CT is used when you don't know what's going on. In virgin cases, CT is universally used. Once you have a lesion and you need problem solving, that's when you go ahead and get an MRI. Sometimes MR may be used for congenital disorders in the neck, but not as a primary study of choice when evaluating for neck pathology. Uniphase or monophasic FDG PET imaging may be used with qualitative or quantitative techniques. At our place, we use only quantitative PET. We use standardized uptake values at all times, especially in the neck, because that's when you can be very, very specific as well as very sensitive, and that is very important. Let's look at sectional neck imaging. For this, we're going to look at the two ways in which we can look at the neck. One is using intravenous contrast, which is helical dynamic computer tomography, and the other is without using contrast. You do not really gain very much by injecting gadolinium DTPA in MRI of the neck. When you do a CT of the neck, it's very important to do it in a dynamic fashion. That's because vascularity, vascular enhancement, and contrast washout patterns are exactly what's going to help you differentiate one entity from another. So it's very important to acquire images during as well as after the injection of intravenous contrast. The typical dose you use is approximately 1 cc per pound of body weight. Exposure delays for your early phase, which is your angiographic phase, is approximately 35 seconds, and then for your extracellular phase, 180 seconds. It's not always necessary to get the second phase in children. We do the early phase because you can look at vascular structures, you can look at early enhancement patterns. You do the delayed phase because you want to assess washout in certain anatomic structures, in all pathological structures, and most importantly, surface mucosal neoplasms. You're going to miss surface mucosal pathology if you don't have delayed phase imaging. So what we do to circumvent all of this, anyone who's not a child is going to get early and delayed phase imaging. You spin the adult from the top to the bottom, and then you spin back after an adequate delay to permit for equilibration. Where do you start? You start at the level of the ear canal, because you want to include the parotid gland. You want to include all the branchial arches, which embryologically will later develop into structures in the neck. Where do you stop? You stop under the aortic arch. Again, the early angiographic phase, you get superb enhancement of your major vascular structures. Neoplasms on the surface of mucosa are going to show up in your early phase because they're going to be hypervascular and they're going to have surface neovascularity. You're going to miss it if you don't get something in the very early angiographic phase. In your late extracellular phase, you're going to get washout within the vessels, but if you've got abnormal neovascularity, you're going to get stasis, and you're not going to see adequate washout from certain tumors. So it's very important whenever you're suspecting tumor to think about the early as well as the delayed phases. Neck MRI is acquired in the neutral position. Neck MRI, again, you start at the level of the ear canal and you stop under the aortic arch. I don't personally think the addition of gadolinium DTPA is going to be of any use, especially if you're going to evaluate further using PET imaging. If you see anatomic abnormalities and they're not variations of normal, they're probably going to need a biopsy anyway. The addition of contrast is not going to increase or decrease your differential diagnosis. It's not going to strengthen your diagnostic confidence. It's going to cost more. You start at the level of the hard palate. The hard palate can be easily identified as an osseous structure on your digital scout topogram as well as on your sagittal localizer images on MR. If you start at the level of the hard palate, you will invariably include the parotid gland. Remember, parotid gland lesions are the #1 missed lesions on MR or CT of the neck, most commonly because they are just not included in the field of view. You are legally obliged to evaluate the entire neck from the parotid gland to under the aortic arch. Do not stop at the level of the thyroid gland. Do not stop at the level of the thoracic inlet. You've got to go under the aortic arch because at that level you might have a few sentinel lymph nodes as well as lymph nodes related to the recurrent laryngeal nerve on that side, which may be the only site of metastatic pathology. Pathology in this location can also cause hoarseness of voice as well as other secondary remote laryngeal problems. So you want to go under the aortic arch, and our technologists are familiar with this. They never stop above it or during the aortic arch. I don't care how much under they go. If they include the symphysis pubis, that's fine as long as I'm under the aortic arch. Looking at your images, you want to analyze it systematically. It's a bunch of spaces, and all these spaces are cylinders. Cylinders placed one within the other to support each other and to give each other anatomic structure. In the midline, we've got cylindrical structures supported by the lateral columns. On either side, you've got chewing mechanisms. These chewing muscles and apparatus has to be supported by the chewing spaces. In the center and more inferiorly, you have the visceral spaces, which have got to do with the aerodigestive tract. And this is a very clear and simple way of dividing pathology within the neck itself. So let's first look at the midline spaces. The entire neck is one long cylinder. In the center of the neck is the airway, which is a long, flexible cylinder. In order to keep the airway patent, you need a rigid cylinder posteriorly, which is the vertebral column. On either side of this are the supporting lateral structures. When you look at the midline, the first thing that comes to mind is the rigid column, which is the vertebral column. You must see the vertebral bodies, and you're going to assess them only briefly for marrow signal abnormalities and pathology in the vertebral column that may progress anteriorly. This is not a cervical spine MRI study, so you're not really assessing the cord to any great detail because your field of view is much larger than the field you would use for a cervical spine MRI. Once you've assessed the rigid tube, you want to assess the upper part of the airway. The airway has no mobile protons, so all you see is signal void. The sagittal sequences are the best suited for assessing the airway. if the airway is not patent, you have to stop looking at other structures and find out what's going on. This could be a surgical emergency if there is near total or total occlusion of the upper part of the airway. The airway may also be assessed in the coronal plane. For these planes of imaging, you've got to use faster imaging, you've got to use gradient or T2 star imaging, because otherwise you can get obscuration of anatomic detail by swallowing as well as respiratory artifact. If your MRI is very comfortable and you're playing soothing music, you could also get snoring artifacts. So we try not to make it too comfortable. You can assess the vallecular, the true and false vocal folds, the subglottic space, and the laryngotracheal interface in the coronal plane. Try not to give too many breath hold instructions. In the neutral position, you can assess most of the airway in the coronal as well as in the sagittal planes. Once you've looked at these two midline structures, go off midline a little bit and look at the other tubular structures that travel from the thoracic inlet superiorly to the skull base. Laterally, you see the anterior circulation, and posteriorly, you see the posterior circulation, the internal carotid artery, the internal jugular vein and venous system, and posteromedially, the vertebral artery within the canal for the vertebral artery. One of the important things to remember is the jugular flow void. While it is called a flow void, there is notorious asymmetry between the jugular flows on either side, and oftentimes the flow patterns may be so turbulent as to give you a pseudo-neoplasm or pseudo-thrombus formation. Almost invariably, these artifacts are seen in the plane of imaging when you're just starting or ending your field of view. So discount any possible thrombus in the first few sections of imaging, because these are unsaturated spins entering the volume of acquisition. Notoriously, the jugular vein is quite asymmetric compared to the other side. This is a variation of normal. Be aware of this and recognize this artifact. You can also, with more experience, visualize the blood vessels, the major blood vessels on the coronal plane, but that typically is a stroke of luck, because not all of the blood vessels in all patients are going to run in a curvilinear fashion. There's going to be a lot of tortuosity, especially in older patients, so you're not always lucky analyzing them in the coronal plane. Looking at the spaces in the midline, this is a useful mnemonic we use. We've got PDR, which is the perivertebral space, the retropharyngeal space, and a potential space in between those two, which you can't really see unless there is pathology within it. This is a true space because any fluid or infection in this area can dissect inferiorly all the way to the retromediastinum or the retroperitoneum. So it's very important to be aware of a potential space between these spaces. The perivertebral space, by definition, is around the vertebral bodies. If it's in front of it, it's prevertebral. If it's behind it, it's postvertebral. So you've got the vertebral body, everything around it is the perivertebral space. In the prevertebral segment, you've got the vertebral body, the vertebral arteries, and the prevertebral muscles. So almost anything originating in the prevertebral segment necessarily arises from the vertebral body or its supporting or arterial structures. And that is very, very important to know in order to limit your differential diagnosis. In the prevertebral segment, you see sheets of lymphoid tissue. These actually belong to the retropharyngeal segment. However, if these sheets of lymphoid tissue are displaced anteriorly, then you know it is bone pathology that is doing this. For example, osteomyelitis can displace the retropharyngeal lymphoid sheets anteriorly. If you have metastases or a collapsed vertebral body, granulation tissue or hematoma from the vertebral body, or metastatic tissue from the metastatic area can enter and displace the retropharyngeal space anteriorly. So anything in the prevertebral segment necessarily arises from the vertebral column. In the prevertebral segment, you have an important muscle called the longus group of muscles. Depending on where exactly this is identified, if it's in the head, it's called the longissimus capitis. If it's in the neck, it's the longissimus cervicis. And there's also longissimus obliquus. Again, detail that is completely unimportant, and it actually takes more time and space to spell them out than to actually look at the length of the muscle. Be that as it may, the importance is anything that effaces the longest muscle posteriorly belongs to the retropharyngeal space. Anything that displaces the longest muscle out and anterolaterally belongs to the prevertebral space. And that gives you an idea of whether the pathology is going to be of osseous origin, displacing the longest anterolaterally, or lymphoid origin, effacing and squishing the longest muscle posteriorly. In the postvertebral segment, all you've got is a few muscles and the fat in between them. This fat is notoriously susceptible for hypertrophy. It can either be physiologic or in pathological conditions. In this fat are embedded nerves and blood vessels which are unnamed, and therefore you can have nerve sheath complex tumors in this location as well. With fat-suppressed sequences, you see chemical shift artifact, and you know that you can get a well-circumscribed fatty deposit in this location, which is a lipoma. Often focal fatty deposits over here may be ill-circumscribed but clinically palpable, and these are just focal fatty depositions. They're not technically a lipoma, and so they cannot really be excised. Paravertebral muscles in this area are also susceptible to any muscular pathology. More importantly, secondary neurogenic pathology. You could get fatty disuse of atrophy because of neurogenic problems rather than primary muscular tumors in this location. There are several paraspinous muscles because you need a lot of complex motion about the level of the neck. Going on to the danger space, again a potential space. This is a space which just permits transmission superiorly as well as inferiorly of infection as well as neoplasm arising from the space in front or behind it. You cannot prima facie diagnose pathology in this location, but you can infer it depending on the extent of the pathology. The retropharyngeal space is behind the pharynx and hence retropharyngeal. If it's behind the nasopharynx, it's retronasopharyngeal. If it's behind the oropharynx, it's retrooropharyngeal, and similarly retrohypopharyngeal. The main constituent of the retropharyngeal area is going to be a lot of lymphatics and lymphoid follicles. So lymphoid problems, whether it be lymphoid hyperplasia, lymphoid hypertrophy, or lymphoproliferative disorders, are the key signature of what happens in the retropharyngeal space. There are no standard limits for thickness. The AP diameter of the retropharyngeal space is not defined because there are variations depending on age, the amount of inspiratory effort during image acquisition, gender, and ethnic differences. However, if there is significant effacement of the pharynx at that level because of retropharyngeal hypertrophy, let's say it's significant enough to block the eustachian tubes, so the child or adult is either symptomatic or you see bilateral mastoid effusions, then you know that that is pathologic enough to warrant direct inspection. Whenever in doubt, it's better to overcall it because subtle and early lymphomas can be missed because you might attribute this to being within variation of normal. Direct inspection assesses surface vascularity, and lymphoid hyperplasia and lymphoid hypertrophy have very, very different patterns of surface vascularity when compared with lymphoproliferative disorder as seen in lymphoma and lymphoma-like conditions. For example, this doesn't look very pathological. These are retropharyngeal lymphoid sheets, but they are thickened. They're thickened more than usual. This is just reactive lymphoid hyperplasia secondary to an upper respiratory infection. Lymphoma could present exactly like this in its early stages. You want, as a radiologist, to be able to catch this before it blocks off the entire airway and has systemically spread. An innocuous lesion we oftentimes see in the retropharyngeal space in the midline is a cystic structure which may or may not infiltrate the longest muscles around it. This is called a tone wall cyst. It's quite common. It's seen in up to 1% of the population. For unknown reasons, it's more commonly seen in schizophrenics, and this may cause periodic halitosis. So these people have bad breath, or other people tell them that they have bad breath. Again, quite incidental, it's just a neurodermal remnant and has no clinical significance whatsoever. However, if it has infiltrated the longest muscles, then you can't remove it entirely. You'd have to remove the longest muscles along with it. So whenever you see this, the critical thing to evaluate is whether you can see a clear fat plane between this structure and the longest muscle on either side. That has surgical importance. Remember, it's a very common lesion. More typical case of lymphoma, 12-year-old child with significant obstruction of the upper part of the airway. Why is this significant? Well, here we've blocked off the posterior segment of the nasal vestibule as well. It's blocking the anterior osteomeatal units bilaterally, greater on the left side, and it's causing significant stasis and secretions in the maxillary sinuses. So this is pretty significant, but we should have caught it earlier. So had the child presented earlier and you had seen subtle or intermediate degrees of swelling of the retropharyngeal lymphoid sheaths, you may have been able to pick it up earlier. So remember, be very, very sensitive to the amount of retropharyngeal lymphoid sheaths that are within variation of normal. Again, there are your retropharyngeal lymphoid sheaths, your longest muscle, and your prevertebral space. Let's go on to the lateral spaces. They're lateral because they're not in the midline, they're on either side of the flexible airway. And they play a great part in supporting the lateral part of the airway. It's made up of a bunch of triangles, and these triangles have anatomic basis because these were palpable topographical triangles that were described by the surgeons. And we've carried off that terminology and brought it into radiology. If it's posterior to the sternocleidomastoid muscle, which is an oblique longitudinal muscle running from the mastoid process to the medial part of the clavicle, it's in the posterior cervical triangular space. If it's anterior to it, we want to analyze it with respect to the styloid process, which is a segment of the temporal bone. Is it in front of the styloid process, or pre-styloid, or is it behind the styloid process, which is post-styloid or retrostyloid? In the posterior cervical triangular space, you don't have very much going on because you've got a few muscles from the suboccipital triangle and you've got the sternocleidomastoid muscle. Invariably, you will find small, non-specific, non-necrotic lymph nodes because of low-grade infections in the neck or in the scalp. Not too much of significance going on over there. So the main thing you see over there are going to be lymph nodes. Look at the lymph nodes. Are they large? Are they necrotic? Or are they significant? Because these lymph nodes may undergo secondary infection, you may get suppurative adenitis, which is not quite an abscess. This is a branchial cleft cyst. This is a remnant. It's a congenital disorder. It is intimately related to the muscles around it because it grew up with the muscles themselves. You can't really describe it independently of the muscles. Often there may be enhancement of its surface, and that's just normal epithelial enhancement. There may even be a degree of reticulation of the fat around it, and that's just developmental. However, if people have tried to biopsy this or somehow or the other intervene, this could be secondarily infected. Most of these are just removed. It is quite impossible to determine before biopsy whether or not these are secondarily infected. Most of them are not, but they are not simply cystic foci. They have complex cystic characteristics when you analyze them using MRI or sonography in the local region. In the pre-styloid and the post-styloid spaces, again, pre-styloid, more anterior, anything in front of the styloid process. Post-styloid, more posterior, anything behind the styloid processes. These are very important because 90% of adult neck pathology is in the post-styloid parapharyngeal space. So you get a neck CT or a neck MR, the first thing you want to look at is the airway. Is the airway patent? If it is, look at the post-styloid parapharyngeal space on both sides. If the post-styloid parapharyngeal space on both sides is normal and the airway is patent throughout the field of view, you have ruled out 90% of significant pathology in adults, the most important space when looking at images of the neck. In the pre-styloid parapharyngeal space, you don't have any vital anatomic structures. You only have fat in that location. You may have few tiny blood vessels or nerves coursing across from it, but no vital structures per se within the pre-styloid parapharyngeal space. Anything that occurs in that location is either by extension or invasion from a neighboring space that is related to it. So pre-styloid space, we're only looking at fat, a few dots, blood vessels or nerves, not unusual. You should not see anything else of any vital significance within the pre-styloid space. In the post-styloid space, however, you've got a lot of vital structures, and they are longitudinal structures. If you see longitudinal pathology within the neck, think about the post-styloid parapharyngeal space. A lot of the older books refer to this as the carotid space or the carotid or jugular space. I prefer not to use this terminology because we tend to ignore things that are not carotid and not jugular and yet live in that location. Don't forget the nervous structures, because neurogenic problems are commonly overlooked because we don't think of them. If you've got a bunch of longitudinal nerves, you can get neurogenic problems, infections, as well as nerve sheath complex neoplasms, and we've got to think of them. So if you remember that there are things other than the carotid artery and the jugular vein in this location, you're going to think of the other pathologies in this area. This is a classic example of a carotid body neoplasm in the post-styloid parapharyngeal space arising at the bifurcation. Another example of a longitudinal neoplasm, salt and pepper appearance, diffuse heterogeneous enhancement pattern, carries all the way superiorly to the level of the jugular bulb. This is a glomus tumor involving the jugular sheath. This can often be overcalled if you have turbulent blood flow and heterogeneous enhancement within the jugular bulb itself. The critical thing in MRI in such cases is to look at the CT scan. You want to look for expansion or erosive changes or secondary reactive changes in the jugular bone around the jugular bulb. If the bone is intact, if it is not significantly asymmetrically expanded, and you don't see any heterogeneous CT pattern, then all this ends up being jugular flow void, causing turbulence effect and patterns of artifact. Longitudinal tumor along the blood vessels, but independent of the blood vessels, displacing the blood vessels away from it, but infiltrating the fat planes around it. Don't forget to think about the nerve sheath complex tumor. It is difficult clinically as well as histologically to determine the difference between a neuroma, a neurinoma, a schwannoma, and malignant degeneration of any of these. So even at post-mortem, sometimes it can be quite challenging to tell one from the other. So you're safer off calling them all nerve sheath complex tumors, as that is a broader category, and you're not going to be wrong about it. The chewing spaces have got to do with the act of chewing, and therefore are somehow or the other related to the mandible. The parotid space obviously contains the parotid gland and is thus named. The masticator space has to do with the actual muscles of mastication or chewing, and the subspaces have to do with the salivary glands or the secretory function of chewing, and are named for the structures that they belie. If you're under the mandible, you're in a submandibular space. If you're under the tongue, you're in a sublingual space. And if you're under the chin, you're in a submental space. The only space that is unpaired is the submental space. The remainder of the spaces are quite symmetric and paired. I caution you about the submental space because if you're not using direct image capture, if you cone down your CT or MR images too much, you always run the risk of missing pathology in the suboccipital triangle as well as in the submental space. So remember to use a field of view that goes from skin to skin. Typically we want to use the tip of the nose and the occipital pole behind, so all of the pathology is included. The mandible is obviously this bright white structure. Behind the mandible, enhancement over here belongs to the retromandibular vein. If you have difficulty finding the parotid gland, if it's excessively fatty replaced, you want to look for the retromandibular vein. The retromandibular vein earmarks the location of the parotid space, and it is a consistent anatomic structure. In the parotid space, you not only have the parotid gland, the parotid gland, more importantly, isn't a simple gland. It is a multi-acinar gland, and the reason you see so much fat in the parotid space is because these acini are separated by fatty as well as connective tissue. So if you didn't see the fat, then you know that that fat has been replaced or infiltrated by some kind of tumor. And that's why you have pathology in the parotid space itself. The facial nerve runs through the parotid space, and that can be a problem because tumors within the parotid space may infiltrate the facial nerve. You don't see the facial nerve per se unless it is pathologically enlarged and has a tumor within one or more segments of it. Remember, the facial nerve is going to start dividing soon enough. Within the parotid space as well, you've got venous and arterial major branches. Every time you do a biopsy within the parotid gland, you run the risk of creating a small fistula. This fistula may feed upon itself because of high volume flow, and you can get a significant hemodynamic problem in that location. Typically, we do not prefer to do parotid biopsies. Parotid biopsies are done using excisional surgical techniques instead, and that way there is very little chance of a sampling error. Within the parotid space itself, between these little acini are small lymphoid follicles. So you've got intraparotid as well as periparotid lymph nodes. Whatever pathology can overcome a lymph node anywhere else in the body, for example, sarcoid or lymphoma or metastases, can occur within the parotid space as well because of these lymph nodes that are scattered within and around the parotid gland. Surgical anatomy, it's important to remember that structures in the parotid space are divided into the superficial segment and the deep segment. These are divided by a line connecting the retromandibular vein and the stylomastoid foramen, which is the anatomic plane in which it's a coronal sagittal plane. It's an oblique coronal plane in which the facial nerve lies. But you do not see the facial nerve, so it's a fairly random plane that exists behind the retromandibular vein. Anything lateral to this plane is in the superficial segment. Anything medial to it is in the deep segment of the parotid space or gland. Why is this important? If you've got a small tumor, it's very key to include in your consultation which segment of the parotid space the tumor lives in. Depending on where it is, the approach to the tumor is going to be retroauricular or endobuccal or transoral. However, if the mass is large enough that it involves both the segments, the superficial and the deep segments, that in most places they're going to have a combined approach. So it doesn't make much of a difference unless the tumor or pathology is really quite small. Mixed parotid neoplasms or pleomorphic adenomas are the commonest tumor in the parotid space. They are solitary tumors, usually unilateral, fairly well circumscribed with variable enhancement patterns. We used to call them benign pleomorphic adenomas. We don't anymore because there is a significant chance of malignant transformation, approximately 10%. They do tend to reoccur, and when they do, they're more likely to be a higher grade or more malignant than they were before. Again, well circumscribed, intraparotid, usually unilateral, and usually solitary. Diffuse infiltrative lymphocytosis is typically a condition associated with autoimmune disorders. So it's very non-specific, but CT is very sensitive. What you've got is these lymphoepithelial cystic dilations within the acini themselves, typically bilateral, and almost always asymmetric. In fact, the asymmetry can be quite striking, and you may be mistaken into thinking that this is a unilateral process. Very, very non-specific. Any autoimmune disorder can be associated with this, including HIV-related parotid disease. Second, branchial cleft cysts. Again, you can have non-simple characteristics. They are related to the sternocleidomastoid muscle. More superiorly, the first branchial cleft cysts are related to the parotid gland as well as the outer ear canal. Again, developmental disorders. They have to be removed surgically before they're secondarily infected. The masticator space has got to do with the muscles of mastication. If it is outside or lateral to the mandible, they're in the superficial segment. If they are deep or inside or medial to the mandible, they are in the deep segment. These are the muscles of mastication. Quite unusual to see primary muscular pathology over here, not unusual to see fatty denervation atrophic change, or fatty tumors that are interspersed within the muscular tissues themselves. The superficial and deep segments, and again they come to a head at the plane of the retromandibular vein where the parotid gland lives. Other muscles, smaller muscles of mastication, the pterygoid muscles, are seen deeper in the masticator spaces. Again, we don't see any pathology related to the muscles, but nearby tumors may invade or infiltrate this space and cause difficulty in swallowing or in chewing. A large, significant tumor, it is disrupting the anatomy. You don't see your typical anatomic landmarks. It is involving the posterior wall of the maxillary sinus. In the appropriate age group, in a male child, this is typically the juvenile nasopharyngeal angiofibroma, a very vascular tumor. Similarly, replacement of normal muscles, muscular atrophy, because there's replacement by neighboring fatty overgrowth. This is a lipoma, fairly well defined, quite a rare tumor, but you do see lipomas in this location. Usually asymptomatic, but can be a palpable finding in some children. Liposarcomas are very different from lipomas. They originate from the same lipid progenitor cell, but they do not have macroscopic fat. As Dr. Mitchell's already alluded to, if you see fat, it's a good thing. If you don't see fat, you've got to worry about bad things like a liposarcoma. A liposarcoma will not have macroscopic fat that is available for you to see through the naked eye. So every time you see a fatty tumor, don't say it's a lipoma, but you cannot rule out a liposarcoma. That is quite a disservice. These are just soft tissue tumors. Again, in the masticator space, like anywhere else, longitudinal tumors, you're going to think of vascular structures because they have longitudinal courses, but you've also got to think of nerve sheath complex tumors. This looks for all the world like something malignant, like a malignant schwannoma, because it has no discrete planes of margination and it infiltrates the fat around it. But this was just a garden variety schwannoma with many internal components. So again, very, very difficult to tell a benign from a malignant nerve sheath complex tumor. These subspaces are under the mandible, under the tongue, or under the chin, and are hence named. The one under the mandible is the submandibular space. Outside of the parotid gland, this is the largest gland, the largest named salivary gland, and it's a submandibular gland. It's also the most problematic because it has variable morphology, variable anatomy, variable cellularity, and it's very difficult to tell submandibular gland pathology from normal variation of anatomy. It could be oriented in different planes. Again, very, very challenging to pick up very early sial adenosis or inflammatory conditions of the submandibular gland. Very heterogeneous texture using either CT or MR, and that is just a component. It's a reflection of the constitution of the salivary gland itself. Very difficult to diagnose tumors in that location. However, the good thing is if the salivary gland in question has a name, parotid, submandibular, sublingual, it's a good thing. A tumor in that location is more likely going to be benign. If it's in a salivary gland that you cannot name, if it's an unnamed or what we call a minor salivary gland, of which there are hundreds, then you're more likely to have a malignancy or a tumor. So a larger gland, a named gland, benign tumors, smaller glands, unnamed glands, minor glands, malignant tumors. And they can be very, very aggressive. Again, there's your submandibular gland. You can identify the mylohyoid muscle at this level. Variable anatomy, variable shape. They can extend inferiorly up to and even inferior to the axial plane of the hyoid bone. They can be oriented transversely or longitudinally, and they can have heterogeneous textures. Again, branchial cleft cysts may be associated with the salivary gland and the sternocleidomastoid muscle. This one's simply cystic, so it has no internal characteristics. But even without being infected, you can have a complex-looking branchial cleft cyst. Tuberculosis, often seen in the anterior compartment of the neck. infiltration of the fat around the lymph node indicates it's an abnormal lymph node. Nothing specific to indicate that this is tuberculosis versus a metastatic focus. Very, very non-specific, but sensitive. This is a slide which should be retired by next year because we just simply don't do any silograms. People find it very painful, but the procedure itself is even more painful than the presentation. We do MR silograms, which don't offer as much detail as we'd like. The protocol is exactly what you do for an MRCP or an MR pancreaticogram, but you're only looking at the neck. Again, the yield is not that high because you've got to stimulate secretion in order to see active areas of pathology. Whenever you do a silogram, if you do them, just as you do in a myelogram, remember you've got to get a post-silogram CT. You may or may not want to do a low-dose pre-neck CT to look for calcifications and then follow it up with a post-silogram follow-through CT. Again, not in favor because it's rather a painful procedure. The sublingual glands are located under the left and right hemi-tongue, so they are related to the sublingual salivary glands as well as the duct of the submandibular gland, which has a very long course. One of the problems of a long course of a duct is that the longer things have to travel, the more likely they are to undergo stasis. And therefore, the commonest pathology in this location is going to be a docholith, which is a calcification or concretion within the course of the duct of the submandibular gland, but it's in the sublingual space because the duct has to travel a long way to get to its exit point, which is in the anterior floor of the mouth. So again, this is a silodocholith or a salivary ductal concretion, but it is within the duct of the submandibular gland, traversing all the way from posterolaterally to anteromedially of midline. Remember, if you've got unnamed salivary glands and if you've got an infiltrative tumor, you've got to think of a malignant neoplasm in that location. They all look the same. This turned out to be adenocystic carcinoma. There's no way you can tell without a needle biopsy. So histology is absolutely required. If you've got liquid in that location, that is a good thing. This is a mucus escape cyst, formerly called a ranula, and these may or may not infiltrate the mylohyoid muscle. They may plunge through the mylohyoid diaphragm, in which case they're called plunging ranulas. The important thing is to determine whether or not they infiltrate the mylohyoid muscle. If they do, the mylohyoid muscle, which supports the floor of the mouth, will have to be removed along with this mucus escape cyst, and therefore you're going to need more prosthetic surgery. If it is a simple cyst and does not invade the mylohyoid floor of the mouth, then it's very easy to do a complete resection of these mucus escape cysts. They're rather common, they're quite symptomatic and painful. They're greenish blue on the surface. The submental space is in the midline. You've got small submental salivary glands. They're very, very small and they have very small ducts. So it's rather unusual to have any duct-related pathology in this location because they empty immediately. You've got fat in this location and tiny lymph nodes. Remember, if you don't expand your field of view and don't look at your source images, you are going to miss pathology in the anterior part of the neck, which is the submental space. If you see submental lymph nodes and you don't see lymph nodes elsewhere, please raise your index of suspicion for tuberculosis. This is a very common location for tuberculosis, even with a normal chest radiograph. Tuberculous adenitis, again, looks like a pathological lymph node, nothing to tell it apart from any other causes of adenopathy or adenitis. Dermoids are germ cell tumors. They have variable constitution. They could be simply liquid or they could have desquamated epithelium within them. Their constitution determines their characteristics and architecture on CT, MRI, or sonography. They are typically midline anywhere in the body because that's where the midline embryologic zipper fails to close and you have remnants of the germ cell layers which proliferate and cause these typical benign appearing structures which are invariably indistinguishable from normal anatomic structures around them. Always midline. If you see something in the midline that doesn't belong and infiltrates normal anatomic structures around it, always think of a dermoid or a germ cell tumor. The visceral spaces are deeper down in the neck, and these are going to also be discussed during your chest section because they have to do with the anterior superior mediastinum. They are typically described by the letter T, the trachea and the esophagus, the thyroid and the parathyroid group, the thymus group, the germ cells, and the true and false vocal folds. These are all in the midline and are vital structures. They have to do with the function of the aerodigestive tract as well as hormonal homeostasis. The tracheoesophageal group is very difficult to assess because the esophagus is typically collapsed. However, this helps you because if the esophagus is not collapsed, if it is dilated and filled with air or fluid, or if you see a mass within the esophagus, you owe it to yourself to do a dedicated esophageal CT, or as we prefer, an esophageal MR. Esophageal MR should always be done in the decubitus position or in the prone position with air distending the esophagus. The better you distend the esophagus, the better contrast you're going to get, and look at the inside of the esophagus as well as the layers of the esophagus. It's supplementary to an upper GI examination. The trachea has intrinsic contrast because you already have air within it. So there's really no need to give additional contrast. Unusual to see tracheal tumors, but if you do, it's more likely going to be something benign like a tracheal fibroma. Tracheomalacia, easily diagnosed using tracheoscopy. If you've got free time, you can do virtual tracheal CT, which is impressive but completely useless. Tracheal fibromas can be seen easily using either CT or MR. It's a mass lesion arising from the inner mucosa of the trachea. Really, it can't be very much else. Is there a chance this is going to be a malignancy? Yes, but it's a very small chance. If you see a tracheal fibroma, you know it's going to be biopsied. So you really don't have to characterize it further other than determining the level it's at. You want to assess the fat around the trachea. You want to see and analyze the area of local spread. Again, most of these are going to be benign and it's not a problem. They're going to end up having histologic confirmation anyway. An esophageal fibroma, much the same way. Before doing an esophageal CT, we want to cover all bases. We distend using effervescent granules. We give barium to cover the inside of the esophagus and intravenous contrast to look at the celiac plexus. So this is a complete esophageal CT. It's a dedicated esophageal CT, and you can see the esophageal fibroma. We're going to talk about the thyroid and parathyroid in a separate talk, so I'm not going to dwell on it too much, except to tell you that these little incidental nodules in the thyroid gland are extremely common. Don't go calling thyroid cancer every time you see a nodule in the thyroid gland, because you're going to initiate a lot more workup than you should be doing because you're extremely sensitized to these nodular lesions. The thyroid is made up of the left and right thyroid lobes, but don't forget the bridging isthmus between these lobes. You can have occult tumors only in the isthmus and not in the lobes, and you're going to miss it because you're not recognizing that as part of the thyroid gland. This is the number one missed area for thyroid pathology. The second area that we miss is when we have ectopic thyroid in the anterior superior mediastinum. Remember to identify the left and right lobe and the isthmus in every CT or MR of the neck. If you don't see it in its normal or native location, look around the migratory pathway of the thyroid gubernaculum to find out where it has come to rest during arrested development. The thymus is really part of the anterior superior mediastinum, but thymic pathology, especially when it's malignant, can extend upwards into the root of the neck. In the thymic space, we often get prevascular or pre-aortic lymphadenopathy. This can be very silent, but you're going to pick it up more sensitively using CT of the neck, which has thinner sections and higher energy of acquisition, as compared to CT of the chest, which has thicker sections. Again, a thymoma can be localized. Malignant thymomas can be infiltrative and can encase along the pleural and pericardial spaces. Biopsy is required. There is nothing specific that's going to tell you whether that tumor in the thymic space is benign or malignant in nature. Even the age group and the gender doesn't really help. Remember, germ cell tumors, any midline mass lesion, you've got to think of a germ cell tumor. In the anterior upper mediastinum, extending to the root of the neck, the seminoma is the commonest type of germ cell tumor. Always think of that whenever you see anything complex in the midline, inseparable from normal anatomic structures. True and false vocal folds, very easily identified on MR, much easier on MR compared to CT, because the false vocal folds, F for false, F for fat, they reflect the signal of fat, be it CT or MRI, and you can see exactly where they're located because they mimic the signal and intensity of fat. The true vocal folds are actually the thyrovocalis muscle. Since it's a muscle, it reflects the signal of muscle. And these make up the true and the false vocal folds. You can assess the anatomy around the true and the false vocal folds. You've got the thyroid cartilage and the arytenoid cartilage. Again, there's a huge cartilaginous apparatus, 28 little pieces of cartilage around that area, which can in any shape, way, or form be infiltrated by laryngeal tumors. The importance of MRI, you have fat around the cartilage. If the fat is invaded, if the fat is destroyed, or if these cartilages show abnormal enhancement, then you know that they have been invaded, they have been violated, and it upgrades the tumor. On CT, on the other hand, it's very challenging because cartilages, especially in this location, have varying degrees of ossification and chondrification and can look markedly irregular. You may be fooled into thinking a cartilage has been eroded and or destroyed when in fact it's just showing a variable pattern of ossification and degeneration as time goes by. Related to the cartilage is a supporting structure which is almost entirely fat. As this fat is invaded, this is the body of the hyoid, the preepiglottic fat, the prehyoid fat, the parahyoid fat, all these fat planes must be intact. If the fat planes are not intact or show abnormal enhancement, then you know that your laryngeal tumor is being upgraded. If you don't do a lot of laryngeal cancer staging at your institution, then just remember to look at the fat around it. Just describe which locations the ENT surgeons call these stations. Just tell them which stations the fat has been violated in, and they can accordingly upstage and upgrade their tumors. But it's very important to look at the fat around the cartilage. The only completely circular cartilage in the human body is the cricoid cartilage. Why is this important? If it is completely circular and there is compromise, you are compromising the airway. And that's going to be a problem because it is a surgical emergency. A laryngocele is an offshoot from the larynx. It is typically filled with mucus, but sometimes you can have saccules because it's an air offshoot. So it's a little outpouching that contains progressive accumulation of air related to the larynx. Laryngeal fractures are quite unusual, but when you see them, it's more the hematoma arising from the fracture that's going to be visualized rather than the fracture itself, because the cartilages are very, very tiny and all of them may not be visible to you if you're using standard sectioning. Laryngeal fractures typically indicate more severe trauma related to the anterior superior mediastinum and the skull base, so this should alert you to other pathology that's going on elsewhere. Laryngopyoceles, for all the world, look very similar to a laryngocele or a laryngeal mucocele, but sometimes may have enhancing margins around them. They are typically secondarily infected. They have to be surgically cured. They can't be just simply aspirated. There is typically a risk factor for obstruction associated with these lesions. Laryngeal polyps, very similar to tracheal polyps or esophageal fibromas in that they are a mass lesion arising from the inner mucosa of a tubular cylindrical structure in the aerodigestive tract. Treatment, again, is excision. Very rarely you may have additional polyps related to the primary and second order segmental bronchi. Quite unusual, but do look at the chest when you've got a laryngeal polyp. Squamous cell carcinoma violating the fat, and that's the clue. You're going to look at the cartilage. You're going to look at the cartilage in even greater detail on fat-suppressed MRI with contrast. If the cartilage enhances, it is abnormal cartilage, it has been violated, you're upstaging the patient. Again, you're looking at indirect evidence around it. So when you look at neck space pathology, look at the airway. That's the first thing. Is it patent or not? If it's not patent, you need to call somebody because this is a surgical emergency. Is this a child or an adult? If it's a child, you're thinking congenital problems, things that can be repaired and definitively excised surgically. If it's an adult, we're thinking of post-styloid parapharyngeal space pathology to do with one of the longitudinal structures, either a vessel or a nerve. Is this a virgin neck, or has there been some kind of therapy? Do you see post-irradiation changes? Are certain vital muscles missing? Remember, if you see someone who's missing a platysma, you know that some kind of modified radical neck dissection has occurred. You cannot do minimal radical neck dissection with an intact platysma. So I always look at the platysma because that gives you a clue as to whether or not this is a post-surgical neck. Is the mass in the midline, or is it lateral? Is it anterior or posterior? And you're going to be able to stage the lymph nodes by looking for them. We're going to talk about the lymph nodes next. It's really hard to have pathological lymphadenopathy because you need billions of malignant cells to show up on a CT scan. You need 1 billion cells for ACC of visible mass. Often we get calls from the operating theater where they actually see the lymph nodes, but even in retrospect on a CT done either that morning or the previous day, even in retrospect, we cannot find the lymph node. That is fairly typical of the neck and the celiac plexus in the retroperitoneum. Pathology is the gold standard, and imaging isn't quite there as yet. Looking at pathological lymph nodes, we've got to determine where they are and whether they're bilateral. Why? If you see pathological lymphadenopathy, prognosis drops. Prognosis drops significantly. The more lymph nodes you see, the poorer the prognosis. Bilaterality is going to drop the prognosis even further, and if you have extracapsular nodal disease, which means the disease is spread outside of the lymph node and is, in effect, in the general circulation, prognosis is very, very poor because this is an indicator of systemic spread of the disorder. How do you determine where these lymph nodes are? Well, according to the Commission for Cancer, we have a very standardized and reproducible way of staging the lymph nodes according to these 7 neck nodal stations. Now, if you're not using this, there is a chart in your syllabus, and you can really use this to help your ENT surgeons further. But remember that you can use the staging of these stations only if you know already that there is head and neck cancer. You cannot use this without knowing the pathological diagnosis of a tumor within the neck itself. Let's look at how we can really simplify this chart. You find a neck lymph node because you see fat, and anything that's not within fat is going to be lymphadenopathy if it doesn't enhance like a blood vessel. And that's why vascular enhancement is very, very important. And then you're going to try and place it. If it is anterior to the submandibular gland, it is level 1. If it is posterior to the submandibular gland, and in the upper thirds of the neck, it is level 2, and the upper thirds has to do with the hyoid bone. So anterior to the submandibular gland, level 1, above the hyoid bone, and posterior to the submandibular gland is level 2. I have a hard time determining what's level 3 and level 4 because the cricoid cartilage may not always be seen on a neck CT or MR because you may miss it in phases of respiration. It doesn't really matter because even if you call something level 3, they're going to upstage it to level 4, and they're going to carry out more neck dissection because, as I told you, you see more lymph nodes at surgery than you will see using CT or MRI. So level 3 or level 4 are still anterior to the sternocleidomastoid muscle, but they are below the level of the hyoid bone. Anything posterior to the sternocleidomastoid muscle is going to be in the posterior triangle, and that's related to the sternocleidomastoid muscle, and that is level 5. Level 6 is in the anterior triangle, but it is not related to the jugular and carotid vessels. It is related to the strap muscles as well as the thyroid and perithyroid spaces. So that's level 6, and most importantly, don't forget level 7. Why? Level 7 is in the anterior superior mediastinum. Almost all of the head and neck surgeons that we work with, if we detect or determine preoperatively that there are level 7 lymph nodes, they are going to involve a general surgeon or a chest surgeon for surgery to excise these lymph nodes as well. So the most important group of lymph nodes is not the differentiation between level 3 and level 4. That's theoretical in the extreme. It's whether or not you've got level 7 lymph nodes. Do you have any extension into the anterior superior mediastinum? This is another very good reason why your imaging has to go under the aortic arch. You're going to miss these if you don't have that included in your field of view. Regardless of what you've read, size of the lymph node doesn't really matter. We don't even report the sizes anymore if they're smaller than 2 centimeters because it's not helping you very much. The size may understage or overstage lymphadenopathy and nodal metastases. There are other people who measure the length and width of a lymph node and give these complex nodal ratios. These people need a hobby. The only reliable and reproducible indicators of pathological nodal involvement are extension outside of the node. So if you have extracapsular extension of pathology, if you have a reticulation of the fat around the capsule, you know that now you have systemic spread of the problem that was earlier confined by the capsule. So that is definitely pathological. If you have a liquefied center, we don't call this necrosis because this is not invariably necrosis. This is just liquefaction in the center that may or may not be related to hypersecretory states or because of central necrosis. This is always pathological. However, this is quite unusually seen in smaller lymph nodes. By the time you have central liquefactive change, the node is big enough and aggressive enough, so you're not really going to miss such a finding. One of the things that does look like this in smaller lymph nodes is central fatty hilar metaplasia. So that is normal, but if the lymph node is very, very large and you see a liquid center, you know that that is nodal liquefactive change. Extracapsular extension, this is probably the worst thing. If you see extracapsular extension, the prognosis is very, very poor. How do you determine whether or not that's going on? You look at the fat around the lymph node. If there is any reticulation of the fat around the lymph node, you know that the pathology has spread much beyond it. If you've had recent intervention, manipulation, or even radiation therapy, that can cause similar changes. So be aware of the clinical setting, because once you say that there is extracapsular spread of disease, you are invoking a far worse prognosis than you could possibly know. So be aware of the treatment history in these patients. Lymphoma or tuberculosis can involve any lymph node in any manner. The larger the lymph node, the more likely I am to determine whether or not it's lymphoma or tuberculosis. However, you can have certain typical patterns which are classically associated with other disorders. For example, metastatic papillary carcinoma from the thyroid gland, very, very hypervascular, so you see bright lymph nodes, highly cellular, or enhancing lymph nodes. But lymph nodes that hemorrhage within them can present identically, so it's a very non-specific finding. Intraparotid lymph nodes, you've got the parotid space and you have a pathological lymph node with some extracapsular spread, very non-specific, because this lymph node behaves exactly like lymph nodes elsewhere, so it could be infectious, inflammatory, or neoplastic. Non-specific, but one does think of sarcoid. Don't forget lymphoma or tuberculosis whenever you see lymph nodes in the neck. Nodal disease in HIV seropositive patients, we're seeing less and less of these as years go by. But when we do see these could be signal lesions. The patient may not even be aware of his or her own HIV seropositivity until you find these incidental findings. These are typically asymptomatic, and you may be scanning the neck for unrelated purposes. So be aware of these incidental findings. The larger the lymph node, the more cellular they are. Again, very, very non-specific. Suppurative lymph nodes. These are not really abscesses, but they're secondarily infected lymph nodes. You don't quite have to drain them as yet because they're not a drainable fluid collection. They're just lymph nodes with liquefactive change associated with them. Too many lymph nodes. These aren't muscles, but there are too many lymph nodes in a location where we shouldn't have anything isoattenuating with muscles. Always think of lymphoma. This is quite unusual, streptococcal infection causing fascial emphysema. Tuberculous adenitis, again, lymph nodes with liquefactive change. So the main thing to take home is liquefactive change or extracapsular extension. Those are reliable ways in which you can determine whether or not a lymph node is pathological. So what you do is you look for the lymph nodes, you look for the pathological lymph nodes, you find the pathological lymph nodes, you stage them, you look on the opposite side and always think of tuberculosis if there is no history of malignancy. New methods of looking at lymph nodes, again, CT and MRI are only so good. FDG PET imaging is really the way to go. In fact, if you have a sizable population of head and neck cancer, there is no reason you should not be doing a PET scan because it makes things extremely easy and logical. We're going to talk about PET scanning in greater detail tomorrow, but just to give you a little taste of what's going on. If you take a typical cell and you feed it with glucose, the glucose is phosphorylated immediately and then it is broken down. So it does not stay in there forever. If you, however, give a cell fructose or a glucose analog, it gets phosphorylated, but it cannot be broken down. It just stays there and can be detected if you can detect the glucose analog. For example, if you give deoxyglucose, which is a glucose analog, you feed it to a cell, it gets phosphorylated and stays there. Let me label it with a positron emitter, which are all those dots or those asterisks over there. It's going to stay in there for a reasonable period of time. So if I can detect the amount of positrons that are being emitted by the cell, I can infer the amount of glucose that would be taken up by the cell because I'm feeding the cell a glucose analog. Malignant cells and active granulomatous infections, we know, are the two most common things that take up glucose more than 2.5 times the level of glucose uptake in the brain and the liver, and that is the basis of PET pathophysiology. So any cell that's taking up far more glucose than it should is probably malignant unless proven otherwise. More about PET tomorrow, but I just want to impress upon you that the role of PET in head and neck cancer, it's much superior compared with MRI, but it's not as specific. So there are some pitfalls in PET. PET is now reimbursable. There are 3 reimbursement Medicare codes for PET in head and neck cancer, and it would be good to be aware of them. However, more importantly, this is probably one of the biggest areas where you can be fooled by false positive PET examinations. You can get false positive PETs in head, face, and neck cancer because you have a variety of problems in this location. For example, 9 cases where you have significant uptake of radioglucose, only the last one of them is actually tumor. All the others are false positive areas. And we're going to look at this when we talk about PET later on in the week. Some of the common false positives we see in head and neck cancer are the accumulation and uptake of glucose by brown fat in the supraclavicular region. A lot of people used to think that this was because of involuntary recruitment of supraclavicular muscles. It is not. It is because of the uptake of glucose by brown fat, which is hypermetabolic. Another area is injection site extravasation. Many of these patients have venous access portocatheters. We try not to inject over there, but sometimes when we inject in the peripheral area, you may get extravasation in that location. So be aware that that's another pitfall. Extreme recruitment of anterior and posterior scalene triangular muscles, the trapezius muscles, and the paraspinous muscles. All these are good locations for metastatic nodal pathology, so be aware. But looking at the numbers, if you consider all these artifacts, and the more you read PET, the more you're going to be aware of the artifacts. If you use PET-CT fusion or registration software or hardware, look at the numbers. PET is much more sensitive and specific in the staging of head and neck cancer compared to CT as well as MRI. Another extreme use for PET in head and neck cancer is to find the unknown primary. Up to 1/10 of all metastatic head and neck cancers have an undetermined primary tumor. It is easier using PET or a combination of PET and MRI to find that unknown primary tumor as it is compared with CT. You can find twice as many unknown primaries using PET to localize where this unknown primary is going to be. Whenever we do head and neck PET, we always get a head and neck CT first. Why? because you want to assess the negative predictive value. If you see no abnormality on a pre-PET neck CT, there is no need to do a PET scan, because the negative predictive value of a CT is 100%. If you do find something on a CT, then it is worth getting a PET study to confirm it. It has been approved. Its sensitivity is very, very high when compared with either CT or MRI. Again, 3 G codes are now available for reimbursement, either for diagnosis, for staging, or for restaging. We're going to end with a little bit about the brachial plexus. Whenever you look at the brachial plexus, what you're looking for is MRI sagittal sequences. You're looking at nerves which are coursing from the spinal cord to their final destination in the axilla. If these nerves are too large, too bright, or they enhance pathologically, you have a brachial plexopathy. Once you find where exactly your pathology is, you can narrow it down to what kind of involvement is actually seen. The trunks of the brachial plexus are more medial, the cords are more lateral. But it is very serendipitous to actually catch them in the oblique coronal plane. And therefore, the sagittal plane is much more useful when compared with the oblique coronal or the axial plane of imaging. Start by looking at the spinal cord and then go laterally. You want to follow the nerve roots from the neural foramina where they become the ventral rami. Determine where your subclavian artery is. As these ventral rami approach the subclavian artery, they're going to be related to the scalene triangular muscles. When they're within the scalene triangle, they form the upper, middle, and lower trunks. As they come together, they dangle over the subclavian artery, and as they dangle, they are the anterior and posterior divisions. The divisions dangle over the subclavian artery. Further laterally, you can see the coracoid process, where they form the cords, the lateral, medial, and posterior cords. And once you get into the level of the axilla, where you can see the scapula, you actually become the terminal nerves. It's very difficult to identify the nerves themselves. Most brachial plexopathy is going to be at the level of the trunks, the cords, or the divisions. And that's where you should probably look for them. You don't really need to give contrast every time you have brachial plexus pathology. Looking for pathological enlargement and pathological locations of these entities is good enough. So to summarize, contrast-enhanced CT is the first modality of choice. MR is used for problem solving and for follow-up purposes. FDG PET is unique because it's very easy to follow lymph nodes and for staging of patients with known head and neck cancer. MR angiography is not yet state-of-the-art because we still have difficulty analyzing the internal architecture of vessels. We can't define ulcers and plaques quite as yet using MR angiography. And unless you're doing angiography, the use of gadolinium DTPA in evaluating neck using MRI is not highly supported. Thyroid space imaging, why? Because it's completely useless. Almost 50% of us in this room have a thyroid nodule. So if I were to go around palpating all of you, which I wouldn't, but had I done so, half of us would have thyroid nodules. And again, very few of us actually have thyroid cancer. So anatomic images, that means sonography, is typically useful only to guide biopsies. You cannot determine, in most cases beforehand, whether or not somebody has thyroid cancer. Functional imaging, nuclear medicine, that is the way to go when it comes to thyroid imaging. We're going to briefly overstate the case using anatomic imaging just because we need these thyroid nodules. We see them all the time. Thyroid cancer is very, very rare. You're more likely to have thyroid cancer if you have a nodule and you're an older male, you've had rapid growth of this nodule, you've had radiation when you were a child, and if you had a family history of thyroid cancer, or you have some syndromic associations. Solitary nodules, just because you have a solitary nodule, it does not make it more likely to be malignant, because almost always solitary nodules are a rare thing. When you actually do surgery, you do find additional multiple nodules, which are the non-palpable ones, and which may indeed harbor cancer within them. So what do? You want to try and determine the function. The function is going to give you an idea whether or not you harbor cancer. Serum calcitonin does show some promise in determining the presence of occult thyroid cancer. It's still undergoing studies, and we don't use it as a standard method as yet. These are the modalities that we use to evaluate thyroid pathology, and except for nuclear medicine, the rest of it is quite spectacularly useless. Conventional wisdom tells us if you've got a solid tumor, it's malignant. If it's non-solid or cystic, it's benign. That's not true, because simple thyroid cysts are quite rare. It's like a simple splenic cyst. It just doesn't happen that commonly. Whether or not you have a cystic lesion, you may have an intramural nodule which may harbor cancer within it. So just because you have a cystic or a solid tumor does not make it necessarily malignant or necessarily benign. Increased flow is more correlative of disturbed neovascularity and therefore underlying occult thyroid cancer. So if you do a lot of thyroid sonography, remember to do Doppler color imaging, because the flow pattern is going to give you more of a clue than the grayscale imaging itself. The same with recurrent cancer. Recurrent thyroid cancer is going to show abnormal flow patterns. Again, when thyroid cancer has been detected, you undergo total excision of the thyroid gland, so there should be nothing that looks like normal thyroid tissue in the thyroid bed. Anything that comes back needs to get a nuclear medicine scan to see if it is functionally active. Going on to cross-sectional imaging, again, large tumor, it is surrounding and encasing the upper part of the airway. Very suspicious for thyroid cancer. Very heterogeneous, liquid areas, few areas of calcification. Clearly almost as big as a face, but this turned out to be very aggressive thyroiditis. So cross-sectional imaging is not going to really show you what's going on. Multinodular goiter, these multiple nodules have various texture, differing architectures, liquid and necrotic change, calcifications, infiltrates the fat around it, looks very, very aggressive and biologically malignant. It's not. Thyroglossal duct cysts sometimes may have a solid component associated with them. Duct cysts are simply remnants of the thyroid gubernaculum. It was arrested on its way. It was on its way from the foramen cecum at the junction of the anterior 2/3 and the posterior 1/3 of the tongue, on its way to these trap muscles, and it got caught up somewhere along the way. It undergoes residual cystic and solid change and stays there forever. It has a small risk of anaplastic cancer, as does thyroid cancer anywhere else. Multiple nodular goiters can infiltrate planes around it and can be deceptively malignant looking. Papillary thyroid carcinoma can look exactly like that. So you're using the anatomic studies only to guide biopsy or to plan radiation therapy. You really can't make the diagnosis based on the architecture themselves. This is a brachial plexus study with involvement of one of the cords using papillary thyroid cancer. So CT and MRI, not really good in determining whether or not the cancer is spread. When it comes to thyroid imaging, nuclear medicine is the way to go. There are two reasons you use nuclear medicine, either for imaging, that is diagnostic, or therapeutic purposes. So let's look at the imaging purposes of the thyroid uptake and scanning. Very important to get immediate images, typically around 30 minutes, 20 to 30 minutes. And for uptake and scans, we prefer to get early uptakes as well as delayed uptakes. Early uptakes are done on the same day, later on in the afternoon, and delayed uptakes are done the following day. So at least a period of 16 hours should elapse. Typically, you have to know what your range of normal uptake is for the geographical area that you live in, because there's variation depending on your water supply. People often ask, why do you bother with the early uptake and the delayed uptake? Remember, you're giving only one dose of oral iodine 123. You're not giving additional doses. You're just doing 2 measurements and 1 set of functional images. If there is extreme hyperthyroidism, all of the uptake is going to occur within the first 6 hours. And you may not see significant uptake at 24 hours in cases such as Hashimoto's toxicosis, and you may completely miss the correct diagnosis because you didn't image earlier. The incidence of this is pretty low. It's less than 10%. But if you do an early and delayed uptake every time and you're consistent then you're not going to miss this. We do not use iodine 131 for this purpose. We only use iodine 123. If you have a malignant nodule, it's probably not going to uptake any activity. So it's not going to organify radioiodine. However, if you have a benign hyperfunctioning nodule, like an adenoma, a goiter, or a toxic thyroid gland, it's going to take up a lot of activity. So a benign nodule is more likely going to be hot. There is a small risk, less than 5%, of warm nodules that may be malignant because they have abnormal function of their own. Again, I have not seen this personally, but these are reported in the literature. For most practical purposes, almost all of your tumors are going to be photopenic or not going to be able to organify orally ingested radioiodine. If you have a nodule, you're not really looking for the tumor, because a nodule that does not uptake could either be malignant or it could be replaced by some kind of storage disorder or burnt out thyroiditis, which both of them are much more common than cancer. You're doing it to define increased activity. It's not the other way around. So you're trying to find hyper-functioning areas or a hyper-functioning background parenchyma. Thyroiditis, more common than thyroid cancer, more common than thyroid adenomas, can present variably. You could have normal activity depending on phase of imaging. You could have diffusely increased activity or diffusely heterogeneous activity. Sometimes in a background of thyroiditis, you may unmask an underlying toxic adenoma. Again, this is a classic example of just overall increased activity, and the gland does look fairly homogeneous. However, you can have heterogeneous distribution because some of your thyroid cells are not functioning and there is a lot of replacement by autoimmune activated follicles between the thyroid colloidal cells. So that can also be seen in thyroiditis. Thyroid adenomas, depending on whether or not they are toxic or whether they're filled with colloid, may present as photopenic nodules. That's a cobalt necklace around a photopenic nodule. Or they may be extremely toxic and take up all of the orally ingested radioiodine, thus suppressing the rest of the gland. So again, variable appearance. Sometimes you may not see the thyroid gland where it's supposed to be, so that's why we use a slightly larger field of view. This is the suprasternal notch, and way above that in the tongue we see the remnant of lingual thyroid. When you have a lingual thyroid, you may not have any other functioning thyroid parenchyma. Remember, the lingual thyroid has to be removed surgically. If there's no other functioning thyroid parenchyma, these kids are going to have to be supplemented by thyroid hormone for the rest of their life orally. Multiple nodular goiter, this is a clinical finding. We feel multiple nodules. The patient is clinically symptomatic. We're doing this pre-therapeutically to determine how strong the goiter is and how much uptake is exhibited 24 hours after ingestion of oral iodine. Non-goitrous uniform uptake in the parenchyma, uniformly enlarged lobes, as well as the isthmus Graves disease. Again, the uptake helps determine how you're going to treat these patients. Typically, after you get your measurement, you're going to calculate the dose of iodine 131. We always explain the alternatives. The alternatives are surgery as well as ablative therapy using radioactive iodine, or they could undergo lifelong anti-thyroid oral therapy. Our typical numbers for the Bay Area are between 6 and 18% at 4 hours and between 10 and 35% at the 24-hour mark. Remember, you've got to know what your local uptakes are at both 4 and 24 hours. I would strongly recommend, if you're not already doing early uptakes, to do them. Remember, there's a separate CPT code and charge when you do serial measurements for thyroid uptakes and scans. So now you've diagnosed benign thyroid disorder with hyperfunctioning glands or hyperfunctioning multiple nodular goiter. How are you going to treat them? Well, initially you've got to dose them, and then you're going to follow up. You do not want to follow them up less than 3 to 6 months after initial dosing. While the radioactive iodine takes its effect within a month after oral dosing, the full effect is not felt for at least a period of 3 to 6 months. So before repeat or serial dosing, we wait for a period of 6 months by the calendar. And that's very important because you don't want to overtreat these people. If you are male, you are less likely to respond to orally ingested therapeutic radioactive iodine. So we are more liberal with men with hyperthyroidism, and we give them larger doses, and there is supporting evidence for this. People often ask, what about the risk for cancer? If you are being treated with this dose of radioactive iodine, the risk of your getting cancer from this dose of radioactivity is no higher than my getting thyroid cancer if I have not been exposed to this. So the amount of radiation is significant enough for short-range radioablation of functioning hyperthyroid cells, but it is not significant enough to undergo malignant transformation. That is very important. It is an ablative dose. Also, there is no significant radiation hazard to the public around you. We typically give them safety precautions, all of which are listed in your syllabus. And most importantly, keep at least a period of 3 hours, not exceeding 3 hours per day with any people who are not pregnant or under the age of 18. We recommend that you keep away from pregnant women as well as children under the age of 18 for at least a 7-day period after dosing. So if you take these general precautions, again, the shorter periods of time you are around other people in the first 7 days, the less the radiation to them, but there is no significant radiation hazard to the public, so you can, of course, go back to work. It has been reported that by treating Graves' disease with radioactive iodine, there is a theoretical risk of worsening of Graves' ophthalmopathy. However, Graves has to be treated by other ophthalmic measures. So we always have to make sure that Graves, the ophthalmopathy, the orbitopathy, is being controlled by other measures at the time of treating it with radioactive iodine. So again, it can progress, especially in smokers. So if you're smoking and you have Graves' disease, I would be a little hesitant to give you a higher dose of radioactive iodine. The higher the dose, the more likely the patient is going to end up being hypothyroid. People lean at different ends of the spectrum. I want to make our patients hypothyroid rather than have them come back for a repeat dose of therapy. If you're hypothyroid, you can be supplemented by oral thyroid hormone for the rest of your life. If you have to keep coming back every time, I have to give you a higher dose, and just the repeat, it's not worth it. We haven't had a repeat patient for at least 8 years now, and I think that's because we dose on the higher side. So we have fairly good success using our methods. The question is, how much do you dose? And this is probably the commonest question I'm often asked, and it's very controversial because no one's quite sure, and that's why we get a multitude of answers. In Europe, everyone gets 10 millicuries. Whether you're a 5-day-old baby or a 400-pound person, you're going to get 10 millicuries. That's it. There's no calculation. We don't want to waste time. We don't have calculators. You're going to get 10 millicuries. Then there are people who like to palpate and like to pretend they can measure the gland by touching it. Now, those people are surgeons. I have never been able to measure a prostate by putting my finger in the rectum, and I'm not going to pretend to be able to measure the thyroid by touching somebody's neck. So again, if you can feel it and if you can weigh it by your fingers, good luck to you. But if you can't, it's really difficult measuring all this. You can't even estimate the mass by sonography. You can blast it by giving someone just under 30 millicuries. That was the old NRC restriction, because they thought that if you give 30 millicuries or above, you'd have to admit the patient, and you've got to watch them till they fall below 30 millicuries. So that was a safe thing. Let's give everyone just under 30 millicuries and we can send them home. But now that the NRC has released us from that limit, you're again at a loss, because now you don't know what your upper limit is. If you're multinodular goiter, you can go over 30 millicuries, but how high do you want to go? Do you want the patients to keep coming back? And remember, if they come back, you've got to give a higher dose than you gave before. So you're really stuck, and you really have to review the literature on your own and make up your mind as to how much you really want to give. And I think it all boils down to experience. I start off by giving 25 millicuries. If they are toxic to begin with, if they've got very, very high radioactive uptake, if it's 95 or 85%, I'm going to start off by giving 30 millicuries. If they come back, they're going to get a higher dose. But this is not a homeopathic 1 millicurie more. I'm going to give them 50 millicuries and be done with it. So they'll never come back to me. And I think that works well. So again, find out what works for you and go with it. Again, these are safe doses, so it's not really one of those tiny 10 millicurie doses. So imaging for functional anatomy, uptake in cancer, therapy for benign thyroid disorder, and for cancer. For cancer imaging, you should not see any activity in the neck because the surgical bed is free of all thyroid parenchyma. Any uptake by radioactive iodine means that there is thyroid parenchyma, either within residual or recurrent tumor. So that is the basis of radioactive therapy over here. Bless you. If you have significant iodine-131 uptake, you know that there is tumor either within remainder cells or within metastatic new lymph nodes. It's that simple. Depending on how extensive the activity is, you are going to stage how progressive the pathology is. For example, not only do we have uptake within the neck, but we've got uptake distally. Very unusual, but you can get metastases anywhere in the body from thyroid carcinoma. The treatment of thyroid cancer starts with total or subtotal thyroidectomy. Whatever is residual after surgery is blasted off. It is primary ablation with radioactive iodine. When you do a follow-up study, you're not going to see any activity. And that follow-up study is going to be 1 week after the treatment dose, or if you have a rising serum thyroglobulin level. We do not follow these patients up at any significant interval. We follow them only if they have rising serum thyroglobulin levels. That's very, very important. You want to know what the level is when these patients are followed up, and our cutoff is approximately 10 milligrams. The staging of thyroid cancer is very interesting because if you have someone who is younger, their staging is much more aggressive. If you have stage 2 cancer and you are under the age of 45, you are M1. You're the highest grade of cancer. And that's because we're much more aggressive with younger patients with thyroid cancer, as this can be potentially fatal and it has a high metastatic potential. Therapy for cancer. To ablate it, that is, after you've done subtotal thyroidectomy or you've removed as much of the thyroid as you can, you want to give an oral dose of 75 millicuries. A week later, you want to evaluate the entire whole body with whole body imaging and make sure that there is no residual uptake. Then when you come back with elevated serum thyroglobulin levels, you're going to look at activity in the thyroid bed, in the local region of the neck, and for distant metastases. Depending on where the activity is, you're going to give higher and higher doses of radioactive iodine. And these are ablative doses, much higher than your dose for benign thyroid disorder. These patients need to be admitted. We've got a separate tower room. We have hazmat material. Food is slipped under the door. We pass them little post-it notes. We talk to them over the intercom. They are treated as if they have the bubonic plague for a period of 1 week or until such time as they are safe to go home. But this is one of those very involved procedures. Remember, if they come back for retreatment, just like in benign thyroid disorder, you're going to give them a higher dose. Do not give them more than 300 millicuries in one setting and not more than one entire curie during the lifetime. And we've never really reached that height. So again, the ablative dose is given because this person had metastatic lung uptake initially. This is at the time after subtotal thyroidectomy. This is lung metastases, normal activity in the stomach because thyroid is excreted by, radioactive iodine is excreted by the salivary glands. Some is excreted in the urine. Pre-ablation therapy, we do see METs. Post-ablation therapy, a little bit of activity, retroperitoneal lymph nodes.